Hey everyone, welcome. Today we are going to crack open arterial blood gas interpretation. And I promise by the end of this video, ABG is going to feel like second nature, whether you're an intern or resident in the ICU at 3 a.m. looking at a panicked ABG result. This video is for you. Here's exactly what we'll cover today. 1. Hydrogen ion concentration trick. 2. The Rome mnemonic, identifying the primary process. 3. Metabolic compensation for respiratory disorders. 4. Winter's formula, respiratory compensation for metabolic disorders. 5. An ion gap, basic, corrected, and delta and ion gap 6. The alveolar gas equation and AA gradient. 7. ABG versus VBG. When can you use the easier one? 8. Urine Anion Gap. Let's go.
The Henderson-Hasselbalch equation gives us the foundation of ABG interpretation. The relationship we need is H plus equals 24 times PaCO2 over HCO3. At normal physiologic pH of 7.40, H plus is exactly 40 nanomoles per liter. So when the pH is normal, H plus is 40. Now here's the most useful clinical trick I was ever taught. You don't need a calculator for this. H plus approximately equals 80 minus last two digits of pH. Let me show you. pH equals 7.40 implies H plus equals 80 minus 40 equals 40. Check. pH equals 7.20 implies H plus equals 80 minus 20 equals 60. Check. pH equals 7.50 implies H plus equals 80 minus 50 equals 30. Check. This is accurate enough for clinical purposes and will save you so much time on rounds. Quick memory anchor. Normal range. pH 7.35 to 7.45, PaCO2 35 to 45 millimeters of mercury, HCO3 22 to 26 milliequivalents per liter. Think of it as the 35 45 22 26 rule. Now comes the most important step. What is the primary disorder? We use the Rome mnemonic. R equals respiratory, O equals opposite, M equals metabolic. E equals equal, same side. What does this mean? For respiratory disorders, pH and PaCO2 move in opposite directions. Respiratory acidosis, pH decreases, CO2 increases, opposite direction. Respiratory alkalosis, pH increases, CO2 decreases, opposite direction. For metabolic disorders, pH and HCO3 move in the same, equal direction. Metabolic acidosis, pH decreases, HCO3 decreases. Metabolic alkalosis, pH increases, HCO3 increases. Clinical application. Step 1. Look at pH. Is it acidic, less than 7.35, or alkalotic, greater than 7.45? Step 2. Look at CO2 and HCO3. Which one matches using Rome? Step 3. That's your primary disorder. Let's do a quick example. pH equals 7.28 implies acidotic. PaCO2 equals 30 implies low. HCO3 equals 14 implies low. Low pH plus low HCO3 implies equal, implies primary metabolic acidosis. The low CO2 is the respiratory compensation. We'll cover that next. Once you identify a respiratory disorder, you need to know if it's acute or chronic. Here are the two rules to memorize. Acute respiratory disorder implies pH changes by 0.008 per millimeter of mercury change in PaCO2. Chronic respiratory disorder implies pH changes by 0.003 per millimeter of mercury change in PaCO2. Example: pH equals 7.24, PaCO2 equals 80 millimeters of mercury. Step 1. Delta PaCO2 equals 80 minus 40 equals 40 millimeters of mercury change. Step 2. Acute 0.008 times 40 equals 0.32 implies expected pH equals 7.40 minus 0.32 equals 7.08. But our patient's pH is 7.24. That's higher than expected acute, not purely acute. Step 3. Chronic. 0.003 times 40 equals 0.12 implies expected pH equals 7.40 minus 0.12 equals 7.28. Our patient's pH of 7.24 is close to this. Conclusion. Chronic respiratory acidosis. This tells us the kidneys have had time to compensate, which is why the pH hasn't fallen as severely. When there's a respiratory disorder, the kidneys compensate by adjusting HCO3. Here's the key table to know. If there is acute respiratory acidosis, then there will be increase in HCO3 by 1 milliequivalent per liter per 10 millimeters of mercury increase in CO2. Similarly, in case of chronic respiratory acidosis, HCO3 increases by 4 milliequivalents per liter per 10 millimeters of mercury increase in CO2. However, in case of acute respiratory alkalosis, there will be decrease in HCO3 by 2 milliequivalents per liter per 10 millimeters of mercury, decrease in CO2. Similarly, in case of chronic respiratory alkalosis, there will be decrease in HCO3 by 5 milliequivalents per liter per 10 millimeters of mercury, decrease in CO2. If measured HCO3 is 40, pure chronic respiratory acidosis. If measured is higher than 40, then there's a concurrent metabolic alkalosis. If lower than, there's a concurrent metabolic acidosis. Now for the other direction. When you have a metabolic disorder, the lungs compensate by changing CO2. We use Winter's formula to calculate the expected PaCO2. For metabolic acidosis, PaCO2 equals 1.5 times HCO3 plus 8 plus or minus 2. For metabolic alkalosis, PaCO2 equals 0.7 times HCO3 plus 21 plus or minus 2. Example: HCO3 equals 10 milliequivalents per liter, metabolic acidosis. Expected PaCO2 equals 1.5 times 10 plus 8 plus or minus 2, equals 15 plus 8 plus or minus 2, equals 21 to 25 millimeters of mercury. Now interpret. If measured PaCO2 is within this range, implies appropriate compensation, single disorder. If measured CO2 is lower, then the lungs are working extra, then concurrent respiratory alkalosis. If measured CO2 is higher, then the lungs aren't compensating enough, then concurrent respiratory acidosis. This is the Winter's formula. Memorize it. Use it every single time you see a metabolic disorder.
The anion gap helps us classify metabolic acidosis. Normal, an ion gap equals 12 plus or minus 4 milliequivalents per liter. But wait, if albumin is low, you must correct it by the given formula. High, an ion gap acidosis can be remembered by the mnemonic mud piles, which denotes methanol, uremia, DKA, propylene glycol, isoniazid/iron, lactic acidosis, ethylene glycol, salicylates. Normal and ion gap, hyperchloremic acidosis is seen in diarrhea, RTA, urethral diversion, and saline infusion. When an ion gap is high, use this formula to detect a hidden second disorder, delta. An ion gap equals measured Ag minus 12, divided by 24 minus measured HCO3 minus. Interpretation: if delta, an ion gap, is less than 0.4 implies hyperchloremic normal. An ion gap, metabolic acidosis, if less than 1 implies high anion gap metabolic acidosis plus normal anion gap metabolic acidosis mixed. If 1 to 2 implies pure anion gap metabolic acidosis, if 2 implies high anion gap metabolic acidosis plus concurrent metabolic alkalosis. The alveolar gas equation tells us the expected oxygen level in the alveoli. Alveolar partial pressure of oxygen equals FiO 2 times PATM minus pH 2O minus PaCO2 over 0.8. At room air, alveolar partial pressure of oxygen equals 0.21 times 760 minus 46 minus 40 over 0.8 equals 0.21 times 714 minus 50 approximately equals 100 millimeters of mercury. Then calculate the AA gradient. AA gradient equals alveolar partial pressure of oxygen minus arterial partial pressure of oxygen implies normal equals 5 to 25 millimeters of mercury. Clinical meaning hypoxia with normal AA gradient implies hypoventilation or decrease FiO2 ventilatory problem. Hypoxia with elevated AA gradient implies VQ mismatch, shunt, or diffusion defect. Great news! For acid-base status, venous blood gas is often sufficient. Bicarbonate is nearly identical between arterial blood gas and venous blood gas, so for assessing metabolic acid-base status, a venous blood gas is often sufficient, much more comfortable for the patient. Use arterial blood gas when you need accurate partial pressure. For example, in respiratory failure, titrating FiO2 or calculating AA gradient. Finally, when you see a normal anion gap metabolic acidosis, then urine. An ion gap tells you why. Positive urine. An ion gap implies kidneys cannot excrete ammonium, implies renal tubular acidosis. That is the kidney is the problem. Negative urine. An ion gap implies kidneys are working fine. That means gut is the problem. Simple rule to remember. Positive equals kidney, negative equals gut. And there you have it, the complete systematic approach to ABG interpretation in 8 steps. Let me recap quickly. 1. Calculate hydrogen ion using the pH trick 2. Identify the primary process using Rome 3. Check metabolic compensation 14254. Apply Winter's formula for metabolic disorders 5. Calculate and interpret the anion gap 6. Use the alveolar gas equation when needed 7. Decide ABG versus VBG based on clinical need 8. Use urine anion gap to differentiate renal tubular acidosis from gastrointestinal causes. Practice this systematically every time and it becomes automatic. The best way to get good at ABGs is to do them consistently. Don't skip steps. If you found this helpful, please like and subscribe. It helps us create more content like this for medical education. Drop your questions in the comments below. See you in the next video.